Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Picture this. It's 2 in the morning.
Oh, man, the classic time for things to go wrong.
Right. 2 a.m. You're scrubbing in for routine appendicectomy. The patient has that classic right lower quadrant pain, maybe a bit of a fever, a slightly elevated white count.
Nothing you haven't seen 1,000 times.
Exactly. You've done this exact procedure hundreds of times.
Mm-hmm.
So you get your ports in, establish pneumoperitoneum, and you look down at the right iliac fossa, expecting to find that familiar, angry little inflamed worm of an appendix.
Yeah,
But instead, you are staring at a grossly distended, tense, mucus-filled cylinder that just looks completely alien. Suddenly, your routine 30-minute case has transformed into this high-stakes oncological tightrope walk.
It really is a heart-stopping moment, right?
No,
Because it completely shifts the paradigm of the operation. You go in with a mindset geared toward simple source control for an infection.
Right, just clip and cut.
Exactly. But the moment you visualize that smooth, dilated structure, you are forced to pivot immediately. I mean, you are now managing a potential malignancy where the sheer mechanical force you apply with your instruments can literally dictate the patient's 10-year survival.
It's wild to think about. And before we unpack this, a quick reminder that this content is for reference only. Always ensure you follow your local guidelines in clinical practice.
Absolutely.
So today we are doing a deep dive into the rare, but quite frankly, highly treacherous world of the Appendiceal Mucocele. We've gone through a massive stack of clinical literature, pathology reports, and surgical guidelines for this.
It's a lot of data.
It is. And our mission today is to equip you with the exact insights you need to recognize, diagnose, and safely manage this condition without triggering, well, catastrophic complications.
And I think the primary challenge here is bridging the gap between the macroscopic presentation you see on the monitor and the microscopic reality of the tissue.
Right.
Because if you don't fully respect the underlying cellular pathology, the instinctual surgical maneuvers we use every single day, they become actively dangerous.
Yeah, and I think the first major misconception we need to clear up is the terminology itself. I mean, we throw the word mucocele around in the OR all the time.
Yeah.
But reading through the pathology guidelines, mucocele isn't actually a histological diagnosis at all, is it?
No, not at all. It is purely a macroscopic descriptive term. It literally just means a mucus-filled dilated appendix. That's it.
So it just describes what it looks like.
Right. It tells you absolutely nothing about the cellular architecture. You might be looking at something tubular or spherical or pear-shaped, but the term covers an incredibly wide spectrum of pathology. And it's rare, too. You'll only see this in about 0.2 to 0.3% of all appendicectomy specimens.
Wow. So really rare. And mostly in middle-aged to older adults, right?
Yeah, exactly.
So since it's a catch-all term, what is the actual mechanism driving that massive distension? I mean, the normal appendix obviously produces mucus, but how does it turn into this high-pressure system?
Well, it depends entirely on where you fall on the spectrum. So on the benign end, you have simple mucus retention cysts, like a phacolith or a stricture blocks the lumen.
Makes sense.
Right. And the mucosal cells, they just keep secreting their normal glycoproteins. But with no outflow tract, the hydrostatic pressure builds and the appendix balloons.
But the lining itself is normal.
Completely normal, yeah.
And-
Just stretched.
Okay, but then the literature shifts into serrated polyps, mucosal hyperplasia, and eventually neoplastic territory. This is where we run into lam and anam, low-grade and high-grade appendiceal mucinous neoplasms. And at the extreme end, frank mucinous adenocarcinoma.
Right, the scary stuff.
Yeah. So is the distension in these neoplastic cases driven by that same simple obstruction?
Not necessarily. In a lamb, for example, the neoplastic cells themselves are hypersecreting mucin. You don't even need a primary obstruction at the base. Yeah, the abnormal epithelium produces such a voluminous amount of thick, viscous mucin that it just overwhelms the organ's capacity. It stretches the muscularis propria to its absolute limit.
And I saw a really consistent threshold mentioned in the data regarding the size of that stretching.
Yeah.
6 centimeters.
Yes, the 6-centimeter rule.
Right. If you're looking at a mucocele that has dilated to 6 centimeters or larger, the probability that you're dealing with a mucinous neoplasm just skyrockets.
It does. And I imagine you're thinking about the tension on the wall, right?
Exactly. I mean, the mechanical tension on a wall that thin means the risk of spontaneous perforation has to be massive.
The physical tension is immense, yes. The wall becomes literally paper thin. But, what makes this pathology so insidious isn't just the physical vulnerability, it's the clinical presentation.
Because it's a chameleon.
It is a master of disguise. Because the lumen is blocked or distended, it causes visceral pain that perfectly mimics acute appendicitis, or sometimes it presents as chronic, recurrent, right lower quadrant pain.
And reading the gynecological crossover data was, well, it was eye-opening.
Oh, for female patients, it's a huge issue.
Right. In female patients, the presentation almost perfectly mimics an adnexal mass. It shows up clinically and radiologically looking just like a complex ovarian cyst.
Which happens constantly. A mucocele is frequently discovered incidentally while a gynecologist is working up presumed ovarian pathology, or even just during a pelvic laparoscopy.
I was trying to visualize the true danger of this, and the old jelly-filled water balloon analogy, it feels a bit too benign now.
Oh, it definitely is.
After reading about the pathology, it seems more like a dandelion that has gone to seed inside the abdomen.
That is a much more accurate physiological model. I like that.
Because if you grasp it roughly, you aren't just popping the balloon of fluid, you're blowing those microscopic neoplastic seeds across the entire peritoneal soil.
Yes. And those seeds are mucin-producing epithelial cells. If a neoplastic mucocele ruptures, whether spontaneously or iatrogenically because you had a heavy hand in the OR, those cells implant on the visceral surfaces, the omentum, the bowel serosa.
And they just keep producing mucin.
Exactly. They take root and just keep doing what they are programmed to do.
Leading to pseudomyxoma peritoneae.
Yeah.
PMP.
Which is a devastating progressive condition. I mean, the peritoneal cavity literally fills with gelatinous ascites.
That's terrifying.
It causes severe morbidity, progressive intestinal obstruction, and if uncontrolled, it's fatal. You are transforming a localized stage 1 equivalent lesion into a diffuse peritoneal disease.
So because pulling the wrong tissue can basically sentence a patient to PMP, flying blind just isn't an option.
Yeah.
We have to know the wall thickness and the structural integrity before we even make that first port incision.
You do. That pushes all the pressure onto the preoperative imaging. Preoperative recognition is your ultimate defense.
Right, catching it early.
If you catch the subtle signs on ultrasound or CT, you can actually plan a controlled atraumatic resection.
Let's talk about those signs, because the acoustic physics behind the ultrasound findings are honestly fascinating.
Yeah.
Radiologists look for the onion skin sign.
Yeah, it's a very classic look.
Why does a mucocele look like an onion on an ultrasound?
It all comes down to the varying acoustic impedance of the mucin. Over time, the mucocele produces layers of mucin with different densities and protein concentrations.
Like rings on a tree.
Exactly. So when the ultrasound waves hit those concentric layers of varying density, they bounce back at different rates. That creates those highly specific laminated internal echoes.
Oh, that makes total sense.
And you also frequently see echogenic wall calcification that throws distinct acoustic shadowing.
But ultrasound is highly operator dependent, right? CT seems to be where we get the really granular objective data.
Oh, absolutely. CT is the workhorse here.
And the classic morphology is a tubular or pear-shaped cystic mass at the cacal pole. I found the Hounsfield unit physics particularly interesting here, like simple fluid or water sits around 0 Hounsfield units, but mucin is heavily proteinaceous, so it attenuates the X-ray beam differently.
Right, so it sits higher, typically between 15 and 25 Hounsfield units. That proteinaceous density is a massive clue.
Okay.
Furthermore, if you are reading a scan for what you think is acute appendicitis, you have to measure the maximal luminal diameter. The established diagnostic threshold is about 1.3 centimeters.
So anything over 1.3 centimeters is suspicious.
Yes. If the lumen is wider than that, especially combined with mural calcification, your differential diagnosis must shift immediately to a mucocele.
I understand the morphologic clues, but here is my challenge to the imaging data. We know size correlates with malignancy risk, but can a CT scan actually differentiate between a massive 10-year-old benign retention cyst and a deadly mucinous adenocarcinoma?
Purely based on diameter, no it can't.
Because a benign cyst can just keep growing.
Exactly. A benign retention cyst can grow to massive proportions given enough time. But CT provides vital morphological red flags that indicate a loss of cellular regulation.
Such as, what are we looking for?
You have to look at the wall architecture. irregular or nodular wall thickening, or the presence of enhancing soft tissue components projecting into the lumen.
So it's not just a smooth balloon anymore.
Right. A benign cyst should have a smooth, uniform wall. If you see nodularity, that implies a complex, infiltrative cellular architecture, and your index of suspicion for mucinous cystadenocarcinoma needs to be extremely high.
Wow. We should also touch on the colonoscopy findings. Obviously, we aren't using colonoscopy to diagnose acute appendicitis.
No, definitely not.
But the sources highlight the volcano sign when these are found incidentally. Why does it look like a volcano?
It's pure anatomy. The mucocele is a high-pressure system sitting on the outside of the cecum. As it expands, it pushes into the cecal lumen from the outside in, creating a smooth submucosal bulge.
But the center's depressed.
Yes, because the original appendiceal orifice, the central point of attachment, creates a depressed crater in the middle of that bulge.
Hence the volcano.
Precisely.
But a mucosal biopsy of that crater won't give you the diagnosis, will it?
Rarely. The overlying mucosa is usually perfectly normal colonic tissue. The actual neoplasm is much deeper in the submucosal or appendiceal tissue.
So the biopsy just comes back as normal colon.
Yeah, but the colonoscopy is still critical because it screens for synchronous colonic neoplasia.
Which is a huge systemic risk we will get to in just a moment.
Yeah.
But let's say the imaging caught it, or perhaps the patient presented acutely. The imaging was ambiguous, and we are now staring at this distended cylinder through the laparoscope.
The moment of truth.
The universal golden rule in the literature is complete atraumatic excision with intact specimen retrieval.
Zero spillage. That is the singular objective.
Let's walk through the mechanics of that.
Mm-hmm.
Because if I'm a junior surgical trainee doing a diagnostic lap for right iliac fossa pain, my muscle memory dictates that I take my laparoscopic toothed grasper, pinch the body of the appendix, and lift it up toward the abdominal wall to expose the musoappendix.
It's what we're all taught to do.
Right. So what is the physiological consequence of that exact motion on a mucocele?
Iatrogenic disaster.
That bad.
Yes. A toothed grasper, or even a blunt traumatic grasper, exerts a tremendous amount of point pressure on a very small surface area. If you are dealing with a lamb, that wall has been stretched to the point of extreme friability. The muscularis propria might be entirely absent in some places.
So the moment I squeeze the ratchets on my grasper,
You exceed the tensile strength of the tissue, the wall tears, the high-pressure mucin blows out into the peritoneal cavity, and you've just seated the abdomen.
just from one squeeze.
Exactly. You must actively fight your muscle memory. You handle the mucocele strictly indirectly.
Meaning I only grasp the adjacent cecal fat or the mesoappendix.
Never the mucocele itself. And when it is finally freed, you must place it immediately into an impermeable extraction bag. You absolutely cannot drag a naked neoplastic mucocele through a port site.
Because it would just smear the cells everywhere.
The sheer forces of the abdominal wall will milk microscopic mucin cells right into the fascia, leading to notoriously aggressive port site recurrences.
This brings up a big traditional debate. Because for decades, the dogma was that if you even suspect a mucocele, laparoscopy is totally contraindicated. You must perform an open laparotomy to ensure gentle handling.
Right, that was the gold standard.
Does the current literature still support that rigid rule?
The paradigm is definitely evolving. Open surgery is inherently safer for tactile feedback and gentle handling for sure. However, several recent high-volume series demonstrate that laparoscopic appendicectomy is perfectly oncologically safe, provided the surgeon has the discipline and the technical skill to use a strictly atraumatic technique and an extraction bag.
But there is a caveat to that, right?
A massive one. If you encounter a mucocele unexpectedly during a laparoscopic case, and you find that the anatomy, the exposure, or the sheer size of the mass prevents you from guaranteeing safe, indirect manipulation, you must convert to an open procedure immediately.
So no being stubborn.
There is zero room for surgical ego here. The morbidity of a laparotomy incision is completely trivial compared to the morbidity of pseudomyxoma peritoni.
That's a great point. Let's clarify the actual extent of the resection while we're in there.
Yeah.
I've encountered this persistent myth among trainees that if you visualize a mucinous neoplasm, you are automatically committed to performing a formal right hemicolectomy.
Oh, yeah, that is an outdated dogma that the recent major society guidelines have thoroughly debunked. A routine right hemicolectomy is no longer considered the default standard for all mucinous neoplasms.
Okay, then what dictates the margin? If I have a lamb that visually appears confined to the appendix, what is the adequate operation?
For a non-neoplastic retention cyst, or a LAM confined to the appendix, a simple appendicectomy with en-bloc resection of the mesoappendix is oncologically adequate. The key is ensuring a clear negative margin at the base.
But what if the base is broad or inflamed, and a standard endoloop or stapler might compromise the cacal wall?
Then you perform a cacal wedge resection using a linear stapler. You take a cuff of healthy cacum to ensure you are well clear of the neoplasm. But you do not need to mobilize and resect the entire right colon.
Good to know.
Yeah, large retrospective analyses show absolutely no survival benefit for a right hemicolectomy over a simple appendicectomy for localized low-grade lesions without lymph node involvement.
So when is the right hemicolectomy actually indicated?
It is reserved for high-risk pathology if you have clear evidence of an invasive mucinous adenocarcinoma, or if there is macroscopic involvement of the cacum that precludes a wedge resection.
Like if it's too embedded.
Right. Or if you see visibly enlarged, suspicious ileocolic lymph nodes. Or, ultimately, if your final pathology comes back with a positive margin that you just cannot clear locally.
So the operative mandate really boils down to prioritize sepsis control if they are infected, guarantee safe atraumatic resection, ensure zero spillage, and meticulously document the exact intraoperative findings for the MDT.
Yes. The operative note is arguably the most critical document in the patient's chart. If you see any spontaneous mucin on the serosa of the appendix or pooled down in the pelvis, you must document its exact location and volume.
Because that changes everything.
That single observation dictates the entire trajectory of the patient's oncological care.
Which transitions us perfectly to the aftermath. The specimen is safely out, it's tucked inside its bag, and sent off to pathology. And the pathologist essentially becomes the judge and jury here. What specific histological markers are they looking for to guide us?
They're evaluating three primary factors: margin status, cellular architecture, and the presence of extra appendiceal mucin. The histology of a LAM is incredibly distinct.
What are they looking for under the microscope?
They look for a villous or flat mucinous epithelium, but the defining characteristic is the loss of the muscularis mucosae and what they call a pushing border.
A pushing border. Meaning the tumor expands outward like a uniform balloon, rather than having the chaotic, destructive cellular invasion you see in a high-grade adenocarcinoma.
Precisely. That pushing border is exactly why the wall gets so dangerously thin. But the most critical finding by far is whether any mucin or epithelial cells have actually breached the serosa.
Let's face the worst-case scenario. Let's say spillage did occur. Or perhaps the patient presented late and PMP was already established. You open them up and find gelatinous ascites throughout the pelvis. How does the systemic management actually work?
That patient requires immediate referral to a specialist peritoneal malignancy center. The gold standard for established PMP is cytoreductive surgery combined with HPEC.
I really want to break down the mechanics of HPEC, the hyperthermic intraperitoneal chemotherapy, because I understand bathing the cavity in cytotoxic drugs like mitomycin C, but why the hyperthermia? Why do we need to heat the chemotherapy to 42 degrees Celsius?
The heat is functionally brilliant. Hyperthermia physically alters the lipid bilayer of the tumor cells, which increases cell membrane permeability. It also impairs the tumor's DNA repair mechanism.
That's clever.
Yeah, but mechanically, the heat increases the penetration depth of the chemotherapy into the tissues, usually up to about 3 millimeters. It literally melts the protective mucin barrier.
Wow, it just melts it.
It does, allowing the cytotoxins to penetrate and destroy the microscopic epithelial seeds left behind after surgery.
But because it only penetrates 3 millimeters, that means the surgeon first has to perform cytoreduction to physically strip out any tumor nodule larger than that.
Exactly. And the cytoreductive phase, it can take 10 to 12 hours. It involves peritonectomies, stripping the diaphragmatic lining, taking out the omentum, the spleen, segments of bowel, whatever is coated in macroscopic disease.
That is a massive operation.
It is. You reduce the tumor burden to microscopic levels, and then the heated chemo wipes out the rest. It is a grueling physiological insult to the patient, but the outcomes are remarkable. High-volume centers are seeing 10-year overall survival rates hovering around 60% for a disease that literally coats the entire abdominal cavity.
60% at 10 years is a massive testament to those specialist units. But even if we avoid PMP and the LAM is fully excised, we still have to execute rigorous post-op staging, like baseline contrast enhanced CTs of the chest, abdomen, and pelvis. And we track tumor markers.
CEA and CA19-9. They are absolutely vital for prognostication.
How so?
Well, if the CEA was elevated preoperatively and then normalizes after the appendicectomy, you have a highly reliable surveillance tool. If it starts creeping back up 2 years later, it is a massive red flag for the delayed development of PMP. EMP.
Now, here's the systemic twist that I found genuinely surprising in the literature. Finding an appendiceal mucocele is essentially a systemic alarm bell. It alerts you to the immediate right iliac fossa problem, but it also mandates that you go hunting for hidden threats elsewhere in the body.
Yes. This is a critical area where general surgeons can sometimes drop the ball if they aren't fully engaged with the MDT. There is a well-documented vital association between appendiceal mucinous neoplasms and both synchronous and metachronous tumors.
Wait, specifically colorectal cancer and ovarian tumors, right?
Exactly.
And the data specifies synchronous and metachronous tumors. So successfully taking out the appendix doesn't mean we've solved the problem. It means an entirely separate colon or ovarian cancer could pop up years down the line.
Yes, your clinical vigilance cannot end in the operating room. Every single patient diagnosed with an appendiceal mucinous neoplasm requires a full colonic evaluation, typically a complete colonoscopy, to rule out a concurrent or developing colon cancer.
And for female patients.
They absolutely require a comprehensive gynecological assessment, including dedicated pelvic imaging and bilateral adnexal evaluation. The ovarian connection is so strong that differentiating between a primary mucinous ovarian tumor and a metastasis from an appendiceal primary actually requires highly specialized immunohistochemistry staining.
It's just staggering. A single isolated pathology in the right lower quadrant triggers a cascade of systemic multi-organ surveillance. It really proves you can't just drop the appendix in a bucket, close the fascia, and sign the patient off.
Not at all. It requires a highly coordinated long-term strategy. For a simple non-neoplastic cyst, clinical review might be enough. But for any neoplastic variant, especially those with questionable margins or high-grade features, the patient is entering a long-term surveillance protocol.
It leaves you wondering about the systemic triggers behind all of this. If an appendiceal lamen dictates that we immediately hunt for synchronous ovarian or colon tumors, what is the shared biological pathway? Is there a subtle, widespread field cancerization effect occurring across the entire peritoneal environment? Or is it a shared embryological vulnerability linking the midgut and the adnexa?
It's a fascinating area of ongoing research, and honestly, it reinforces why multidisciplinary awareness is the only way to manage these patients comprehensively.
That's the real mystery we are left to untangle. We've gone from the 2 a.m. laparoscopic scrub-in all the way to a decade-long MDT surveillance plan. If you like this content, then do not forget to share with at least one of your colleagues or friends and spread the word. Also, check out our YouTube and other social media pages. And do check our previous season and episodes with some very relevant topics.
Keep your index of suspicion high, respect the tissue, and never treat a dilated appendix like a routine case.
Great advice. Until next time, keep looking deeper. Take care, everyone.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.